Good afternoon, everybody. I'm Dr. Vasala, consultant anesthetist from Department of Anesthesiology and Critical Care, and today we are going to discuss how we are going to approach a patient present with polyuria. So this is a very small case scenario, and assume that you are the house officer or you are the medical student who is looking after this patient. This patient is 30 years old, and he complains that increased frequency of urine and loss of weight about 5 kilos during last month. So how do you approach this patient? And he asks from you, what could be the reason? So can you explain them to me? What are the key words in this case scenario? So first keyword is age of the patient. He's a 30 years old patient. Second one is increased frequency of urination, and third one is loss of weight. So is it usual for a 30-year to have these symptoms, increased frequency? He says that he has to get up 5 to 6 times in the middle of night to go to washroom, and he also says loss of weight about 5 kilos. Are these symptoms normal to him? They are not normal to him. So what are the causes of increased frequency or increased amount of urine? So how do you relate this to your physiology knowledge? Now his physiology has changed. So can you remember the physiology behind the urine formation? So can you remember this picture? So urine output or excretion is depend on filtration, reabsorption, and secretions. Any change in the filtration, any change in the reabsorption or secretion, urine output is going to be changed. Okay, so give me an example. What can increase the filtration? So as an example, if I give 2 liters in 2 liters of intravenous fluid to a patient, what will happen? So volume is going to increase. With that, venous return is going to increase. So cardiac output will be increased, and the blood pressure is going to increase. So increase in the blood pressure will be detected by the baroreceptors. Then the mechanisms are activated to reduce the blood pressure and the reduce the volume. Okay, the urine output is increased by increased filtration. Okay, so that is how the filtration uh, how the filtration is affected. Second one is reabsorption. If you look at, this is the functional unit of the kidney, a nephron. So if you look at this picture, you can see various part of the nephron, various molecules are absorbed in different concentrations. So proximal convoluted tubule, it's absorbed almost all solute. It absorbs glucose, it absorbs amino acids, most of the water and the sodium. Okay, when you go down in the descending loop of Henle, it absorbs only the water, and thin ascending limb, you know there is a transporter, sodium potassium chlorine transporter, and it transport it's a co-transporter. It moves sodium, chlorine, and potassium out from the tubule. Okay. Okay. When you come to the uh, distal collecting duct, and you can see this effect of the aldosterone. Sorry, not aldosterone. It is ADH. So, and the basolateral membrane, the ADH receptor is there. When this receptor is stimulated, what will happen is it incorporate these aquaporin molecules are incorporated into the tubular lumen, and the water absorption is increased. Okay, if any one of them, if the filtration is affected, if the absorption is affected, if the secretion is affected, urine output can increase or decrease. Okay, so in this patient again, and so you have taken the history and you have examined the patient, and you can do some bedside tests. So you can send these samples to the lab, but the facilities are available in your ward to do bedside test. According to history and examination, you do a random blood sugar and the urine sugar. So urine sugar comes as very high, and the random blood sugar is also very high. So what is the possible cause for increase in urine output? So what is the main reason? So in this graph was taken from your physiology book. So here it says that absorption of solute in the proximal convoluted tubule. You can see almost all the glucose almost all the amino acids are absorbed from the proximal tubule. So what will happen if now this glucose, these basically absorbed from the facilitated diffusion, so to a transporter. This transporter is saturable. Okay, if it is fully saturated, no more glucose can be absorbed. It's going to remain in the tubular lumen with that water. It is glucose is osmotically active particle, and water is going to remain with the glucose, and the urine output will be increased. In the same picture, you can see in the right hand corner what is the relationship between the plasma glucose concentration and the glucose reabsorption. You can see there is a now absorption is proportional to the plasma glucose concentration up to one level. After that, it's going to be static. Why? The receptors are saturated. Okay, that's what has happened to this patient. So large amount of glucose in the tubules, osmotically active, and urine output has increased. Okay, so what is normal blood sugar then? What is the normal blood sugar? Okay, how it is maintained within normal limits? You know, normal blood sugar is less than 100 milligrams a deciliter. How it is maintained within the normal limits? Blood sugar is basically maintained within normal limits by two hormones. One is insulin, other one is glucagon. Okay, so from where these hormones are secreted? From the pancreas. So pancreas, you have, you know, there are two types of cells, alpha cells and the beta cells. Beta cells secrete insulin, alpha cells secrete glucagon. When the plasma concentration of glucose increases, as in this picture, insulin secretion increases. So it takes what does it do? What does the insulin do? So here in seconds it increases transport of glucose, amino acids and potassium into insulin sensitive cells. That happens in seconds. Then there are actions take place in minutes, and there are actions take place in hours. So action takes place in minutes, increase the protein synthesis and increase the glycogen synthesis. So action takes place in hours is the fatty acid synthesis. So in the right hand corner, right hand side, you can see what happens in the cellular level. Okay, so now in this picture, during daytime you take meals, blood sugar concentration increases, and it is uh, brought back to normal by insulin. So during the night time you don't eat anything, so glucagon start to function, and then the blood sugar concentration brings back to normal by glucogenolysis and the gluconeogenesis. Okay, so this happens in a where it's happens uh, when the glucose concentration, insulin concentration is lower for a longer duration, then these things can take place. You can see, so decreased glucose uptake into the cells end up with the hyperglycemia and the glycosuria. So with that, osmotic diuresis and the electrolyte depletion. So increase protein catabolism. Okay, that's the reason why the protein catabolism and the uh, uh, now breakdown of fat cause weight loss in these patients. So increased lipolysis cause large amount of free fatty acids into the circulation. Those free fatty acids are absorbed by the liver and convert into the ketone body. So end up with the ketone urea. Okay, so those are the long term effect of lack of insulin. Okay, so what is diabetes actually? So according to the WHO definition, diabetics, the term diabetes describe a group of metabolic disorder characterized and identified by the presence of hyperglycemia in absence of treatment. That is diabetes. How do you diagnose this diabetic patient? So it depends on the your blood sugar level and also HbA1c level. So your normal limits of HbA1c less than 5.6 and your blood sugar should be less than 100 milligrams per deciliter. So if those HbA1c is higher and the blood sugar levels are higher, you can be classified as a pre-diabetic patient or diabetic patient. If it is more than 6.5, you are diagnosed diabetic patient. If your fasting blood sugar is more than 126 with symptoms, you are a diabetic patient. Okay, so what are the main types of diabetics? There are four types actually. So type 1, type 2, gestation and other types. So we will basically focus on the type 1 and type 2 diabetes mellitus. What is type 1 and what is type 2? Type 1 is no insulin. Okay, so there is no insulin production from the pancreas. So complete loss of insulin. In the type 2 diabetes is insulin is there. Okay, so reduced secretions of insulin, or there is a resistance to insulin at peripheral level. So type 1 is no insulin in the circulation. Type 2 is insulin is there, but there is a resistance. So here what happened in the type 2 diabetic patients? So initially, so they start gradually, they start to develop insulin resistance. When there is insulin resistance, so to match the requirement, insulin secretion is increasing and the beta cell function also increase. With time, beta cells are exhausted, and then you can see the insulin level comes down. Okay, then they become diabetic patients. Okay, so again this same patient. So how do you know this patient? Now you know this patient's blood sugar is high now, urine sugar is high, so most likely a diabetic patient. So then you have to identify what type of diabetes is type 1 diabetic patient or type 2 diabetic patient. So that's why your clinical symptoms are very important in these patients. In type 1 diabetics, it is usually, most of the time, its onset is uh, early onset. Very young people are affected in type 1. So sometimes they suddenly present to medical ward or emergency department. So DK is the first presentation. Diabetic ketoacidosis, you will learn with time. So it may be the first presentation. So they can present as acute illness with polyuria, polydipsia, or polyphagia. Okay, so other symptoms, they may have other symptoms of fatigue, visual imbalance, poor wound healing, and the weight loss. That is basically because of the loss of fat and the protein. Okay, those are the main symptoms of type 1 diabetic patient. Type 2 is a gradual onset one. You don't know you have diabetes. Sometimes you come to hospital with the chest pain. When you are investigated, then uh, usually found that your blood sugars are high. Okay, so those are the main ways actually. So diagnose type 1 and type 2 diabetic patient. So its diagnosis is not enough in these patients. So in addition to blood sugar and the urine sugar, and what other things you want to know these patients? So it's a long-term disease, and it's a multi-system disease. In it affect many organs. So you have to, once you diagnose this patient, you should know what are the other complications patient has developed up to now. So complications of diabetes, there are two types: the acute complications and the chronic complications. Acute complications are diabetic ketoacidosis, okay, or hypoglycemia, okay, severe hyperglycemia. So non-ketotic hyperosmolar coma. So just read about this. These are the acute complications of diabetic patient. Then you have a chronic complications. So chronic complications are again divided into two: microvascular complications and the macrovascular complications. So microvascular complications are retinopathy, eyes are affected, they come with a blurred vision and a diplopia on cataract. Neuropathy, so it may be autonomic neuropathy or sensory neuropathy, so just you feel like walking on cotton. Okay, and the nephropathy is a renal damage. The diabetic foot and dermopathy. So when you go to ward, when you are taking history of long-standing diabetic patient, just examine the skin. You will see a number of skin manifestations of the diabetic patient. So then the macrovascular complication, CVA. Okay, you ask from the history. So uh, now any history of cerebrovascular events. So cardiovascular system is myocardial infarction, peripheral vascular disease is the claudications. So the macrovascular complications and the microvascular complications. So while you are taking history to diagnose the patient, you have to take the history and examine and do the relevant investigation to look for the complication for look for complications. So now assume that you have taken the history, you have sent the blood samples, and you have diagnosed this patient is a diabetic patient. Now what are you going to do with this patient? So what is your management? What is your management? So all these problems are because of the lack of insulin. Your target should be to give insulin for this patient. So his main symptoms were the weight loss and the polyuria and increased frequency of urination. So there are certain problems. So while you are addressing the blood glucose concentration, while you are trying to bring the sugar back to normal using insulin, and you have to see what other complications patient has developed. So I mentioned there are acute complications of diabetic patients. One is a diabetic ketoacidosis or hypoglycemia. This is a hypoglycemia is unlikely in this situation, but it may be a diabetic ketoacidosis. Okay, so and dehydration and electrolyte disturbances. So you look for those complications while you are giving insulin, and you have to look for those complications. If the patient is dehydrated because of the polyuria, you have to rehydrate the patient. With the dehydration, there will be volume loss and blood pressure will be dropping and organ perfusion can be affected. Okay, so you have to replace the volume. So your targets of managing these diabetic patients should be uh, focus on keeping the blood sugar normal. So in type 1 insulin dependent diabetic patient, you will have to start insulin at the beginning. Okay, no other replacement. But in type 2 diabetic patient, that is because of insulin is there, that is basically because of the resistance to insulin. You can start with oral drugs. So you might start with oral drugs at first, but later you might convert to insulin. So first line drug in most of the diabetic patient is metformin. Okay, then gradually you can start the other oral hypoglycemic drugs. And when you take histories, when you see patients, you will see some of these patients are on single oral hypoglycemic drugs and some are on multiple oral hypoglycemic drugs plus or minus insulin. So you have to control the blood sugar in these patients. So especially in type 2 diabetic patients, those patients are always most of the time associated with the metabolic syndrome. Their body weight is high. Okay, so there are lifestyle modifications you can adapt. So one is a cessation of smoking, stopping alcohol, and weight reduction. Okay, regular exercises. So and changing the dietary patterns. Those are lifestyle modifications you can uh, adapt to control the keep the blood sugar within normal limits. And so while you are controlling the blood sugar using lifestyle modifications and the pharmacological techniques, you have to look for complications and take necessary steps to prevent complications. Okay, so and assume that when you examine this same patient, when you examine this patient, his temperature is 39 now. He's running a fever and he is a little bit drowsy. So and his blood pressure is 130 by heart rate is 130, blood pressure is 90 by 60 millimeters mercury, and he is breathing fast. He is breathing at the rate of 40 and his saturation is 99. So that is your clinical examination findings. And when you do investigation, you found random blood sugar is very high, 450 milligrams per deciliter, hemoglobin is 18 grams per deciliter, and CRP is 200. Okay, and you at the same time use the blood gas analysis. When you do the blood gas analysis, you use the pH is 7.1. Oxygenation is fine, but carbon dioxide is 20. Sodium is 144. Potassium is 6.1. Chlorine is 90. Lactate is 1.9. Bicarbonate is 20. How do you explain these investigations? Temperature is probably high because of a underlying infection. You can see the temperature is 39 and the CRP level is 200. Those are very high. Why the CRP levels is very high in this patient with the fever? So most likely this patient is running a fever. So what happened in diabetic type 1 diabetes is that so when they develop fever or infection after a myocardial infarction or after a surgery, so maybe after a stroke, their insulin requirement goes up. Okay, so body can't produce adequate amount of insulin. Now they can push into a condition like diabetic ketoacidosis. So, and as I explained earlier, and uh, what will happen is that fatty acids are metabolized and taken these free fatty acids are taken up by the liver and they are converted into the ketone bodies. Those ketone bodies are very acidic. Now liver release a lot of acid into the circulation. That acid need to be neutralized. So you need the knowledge there, you need the knowledge of the acid base metabolism of the balance of the kidney. So there are three main mechanisms are there. One is a buffering system of the body, second one your respiratory system, third one is your kidney. So the buffering system comes start to play in second, and the respiratory system in minute, and the kidney in hours and hours to days. So what happens is when these acids are secreted into the circulation, those need to be neutralized, though the body use the bicarbonate buffering system. That's why the bicarbonate levels are low. Okay, so end result is that now next system to come is to pay is the your respiratory system. So you need to neutralize these acids, you combine with the bicarbonate, and carbonic acid is formed, and it is metabolized into water and the carbon dioxide. This carbon dioxide need to be removed. That's why your respiratory rate is very high in this patient. So, and that's how you explain this blood gas acidosis, and buffering bicarbonate is used to buffer, and the respiratory system is increase respiration to remove the carbon dioxide. Why the potassium is 6.1 is that there is potassium and hydrogen counter transport. So when the plasma concentration of hydrogen ion increases, it moves into the cells and the potassium comes out from the cell. That's why the potassium concentration is higher in this scenario. Actually, this is a situation with the diabetic ketoacidosis. So management should basically focus on the hydration of the patient and maintain the vascular volume and controlling the blood sugar levels and controlling the electrolyte disturbances, and third one is the underlying cause. So this is a most likely after infection, so you have to treat the infection to control the blood sugar level. Okay, so we move into the second case scenario. This is a patient, a 42 years old patient, present with increased urine output following a head injury. So take about 1 to 2 minutes and think what could be the reason in this scenario. Okay, so can you remember this picture? So can it be a problem at the proximal canonical tubule? Yes, it may be a problem at the proximal canonical tubule, where maybe a diabetic patient, you don't know. Okay? So, and can it be a problem at the thick segment of ascending limb? So there there is a sodium, potassium, and chlorine and co-transporter. It can be affected by drugs like furosemide. Patient may be on fusamides and the sodium absorption is inadequate, so urine output is increased. So can it be because of the mannitol? Mannitol is osmotic diuretic, so it is osmotically active. It's going to retain water in the tubular lumen. So urine output may be increased because of what? Because of mannitol. So can it be at the collecting duct level? Can it be because of the ADH? Yeah. So yeah, it could be because of the ADH. And so what is ADH actually? This is called antidiuretic hormone. It is secreted from the posterior pituitary. So if there is a problem with the secretion, so or if secretion is normal but there is a problem at the receptor level, so ADH level in the circulation is normal but cannot work. Okay, so and cannot work. So depending on that, this is actually a case of diabetic insipidus. There are 4 types of diabetic insipidus actually. First one is a central diabetic insipidus, second one is a nephrogenic diabetic insipidus, and third one is a dipsogenic diabetic insipidus, fourth one is a gestational diabetic insipidus. What happens is a central diabetic insipidus is there is an absolute reduction of the ADH in the circulation. Secretion is impaired. In the nephrogenic diabetic insipidus, adequate amount of plasma ADH is available, but it cannot work because of the impaired function of the receptor dysfunction. So dipsogenic diabetic insipidus is actually there are people who cannot control the thirst mechanism. They keep on drinking. Okay. Gestational diabetes is where placenta secrete vasopressinase, and so vasopressinase metabolize ADH. So ADH level is low in maternal patients, and when the ADH level is low, water is not reabsorbed. So there is no mobilization of aquaporin into the luminal surface of the tubule. So water excretion is increased. Okay? So, and what are the reasons? Now, these are the four types of diabetic insipidus, and what are the causes for these four types? Central diabetic insipidus, nephrogenic diabetes insipidus. So, central diabetic insipidus, I mentioned earlier, yeah, the pituitary, there's a problem with the pituitary gland. Posterior pituitary is damaged. What are the conditions that damage the posterior pituitary? Example, a head injury. In this case scenario, this is a patient with a head injury and a brain tumors, maybe meningitis or pituitary ischemia or neurosurgery can damage the posterior pituitary and impair the secretion of the ADH. In the nephrogenic diabetes, there is a problem at the receptor level. It may be hereditary or it may be acquired. Hereditary means that there is a mutation in ADH receptor and it's very rare, and the receptor is malfunctioning. In acquired ones are pregnancy, some renal disease, and adverse, because of the adverse effect of some medication, the receptor can be impaired. So that is the basically problem at the receptor level. How do you differentiate these conditions? Whether this patient is having central diabetic insipidus, nephrogenic diabetic insipidus, or other conditions. And any condition, you know, it is your history, examination, investigation to diagnose this problem, and you have to do other investigation to look for the etiology and the complications. So in this patient, history says this patient had a head injury, so most likely patient's posterior pituitary is damaged. That's why the ADH secretion is impaired. So examination findings are actually so features of clinical features of dehydration. Now in both situations, both situation, urine output is increasing, patient is losing water, okay, and they are generally dehydrated. But in the primary polydipsia or dysogenic diabetic insipidus, this is the other way around. Patient drinks a lot of water, that's why the urine output is increased. So always you can identify a pregnant patient. So clinically, what you get only you can say the urine output is increased. So patient is producing large amount of urine. So to say it is a diabetic insipidus, patient should produce large amounts. Usually their urine output can go up even more than 3 liters per day. When to say diabetic insipidus increase urine output, it has to be more than 2.5 or 3 liters per day. Okay, so in investigation, how are you going to plan your investigations? So what happens when there is a increased urine output? So what happened to serum osmolality? What happened to the serum electrolyte concentration? What happened to the urinary osmolality, and what happened to the urine electrolyte concentration? So normally serum osmolality, urinary osmolality is 500, just around 500 or 800. But when the patients are producing a large amount of urine, osmolality is reduced. Okay, so and the other on the other side is the serum osmolality. Generally they are dehydrated. When they are dehydrated, their serum osmolality increase. So in this patient, what you usually see is serum osmolality increases, serum sodium concentration is increases, but urinary osmolality is very low because passing lot of diluted urine. Okay, so how do you differentiate these things? So this is a patient is suspected diabetic insipidus. What do? You do the plasma sodium and osmolality. At the same time, you do the urinary osmolality. Okay, so when the result comes as you have the hyponatremia. So your sodium concentration is very low and the plasma osmolality is low normal. What does it mean? So plasma is diluted. And so that is, we are taking lot of water. It is a feature of primary polydipsia. But if your serum osmolality is high and your sodium concentration is very high, now you are dehydrated. Okay, so that is most likely diabetic insipidus. Okay, your clinical diagnosis is the now either it's a you can decide whether the primary polydyspia likely or it is a case of a diabetic insipidus. So then you can do to confirm diagnosis. You say the water deprivation test. You don't let the patient to drink water for 24, maybe on 24 to 48. What will happen to the primary polydyspia patient? Everything normalize. But in a patient with a diabetic insipidus, what will happen? So the patient is keep on producing the urine output. But in the primary polydipsia, urine output drops. But in diabetic patient, the problem worsens. The urine osmolality remains low, and the plasma osmolality is increased. Why? Further dehydration. So differentiate whether it is central diabetic insipidus or nephrogenic diabetic insipidus. What you can do is give synthetic ADH. When you give synthetic ADH, if it is a case of central diabetic insipidus, everything is normalized. It's not going to happen with the nephrogenic diabetic insipidus. That's how you diagnose central diabetic insipidus and the nephrogenic diabetic insipidus. Understand? Okay, how do you manage this patient? So, diabetic insipidus, there are four varieties. It is central diabetic insipidus, nephrogenic diabetic insipidus, and primary polydipsia and the gestational diabetic insipidus. So, treatment of the gestational diabetic insipidus is that now delivery of the baby. So, patient might have to wait until the delivery, but complications you will be able to treat because might have to take adequate amount of water. So central and nephrogenic diabetic insipidus. Central diabetic insipidus, the main problem is the inadequate secretion of ADH. So you have to supply the ADH. So synthetic ADH are available, which is called the desmopressin. So you can use it intranasally, intravenously, or in subcutaneously. So when the patients are given desmopressin, you will see that the urine output is gradually coming down with time. So nephrogenic diabetic insipidus. So basically you might have to find out what is the underlying reason. If it is because of the drug like lithium, you will have to stop the lithium, or if it is because of the hypokalemia or hypocalcemia, treat underlying cause. So you will see that now urine output is gradually coming down. And other main aspect you have to focus on is with these conditions, especially the nephrogenic and the central diabetic insipidus, patient will be dehydrated because of the large amount of urine urine that is produced by the patient. So you have to rehydrate the patient. Problem is you can't use fluids containing large amount of sodium, so you have to you have to give fluids with lower concentration of sodium. Initially, if the patient can take orally, you give oral fluid without sodium. If they cannot take oral fluids, you have to use fluid such as half normal saline or dextrose to rehydrate the patient. Thank you. So this lecture actually was designed to discuss with you in the lecture theatre, and anyhow I had to upload this to the Moodle. What I will do is I will give you some case scenarios, and you have to explain the case scenarios of polyuria. You have to explain the physiological basis for polyuria and what investigations you do to confirm your diagnosis, what clinical signs and symptoms you expect in these patients, and what is your management plan. Okay, probably I will give 3 or 4 case scenarios. Okay, again, thank you.